Hi everyone, this is my lecture on peripheral vascular diseases. Okay, so to begin this lecture, I'm going to be talking about the arterial side first. So first let's start with the diseases of the aorta. So one of those is going to be aortic aneurysm. Now an aneurysm is actually a swelling or an enlargement or a dilatation of the vessel. Okay, and by definition, it's about 50% greater than the normal width of the aorta. So for example, typically in the ascending portion of the aorta, that's about 3 centimeters in diameter, whereas the descending portion is anywhere from about 2 to 2.5 centimeters. And so this would be a 50% increase in the diameter of the aorta, and it's localized. Okay, and we can classify that as either true or false. If it's a true aneurysm, that means that the swelling or the dilatation involves all 3 layers of the artery. So for example, remember there's these 3 layers. We have the intima, the media, and the externa. So all 3 are being bulged outward or dilating. Okay. And if it's false, false just means it doesn't involve all 3 layers. Okay. So you can actually have, let's say, just the externa that's kind of billowing out a little bit. And that could happen due to an infection or trauma or something of that nature. Maybe some endothelial damage and blood got in there and so on, and created an outpocketing. But that's not we would call that a false or a pseudo aneurysm. Okay. Now, of the true type of aneurysms that involve all 3 layers of the artery, we have what we call saccular and fusiform. And if you take a look at the cartoon I have over here, I use yellow here. So this is saccular, and you can see that it involves a portion of the wall. So remember, it's all 3 layers that are bulging out there, but it's only on one aspect of the wall. Whereas in a fusiform is more symmetrical dilatation that involves the whole circumference of the artery. Okay, but in both cases, saccular or fusiform, we're talking about a true aneurysm that involves all 3 layers. In the pseudoaneurysm, which is our false aneurysm, you'll notice if you pay attention to this cartoon here, you'll see that it's showing a little opening there where you have a maybe a ruptured endothelium or a mesothelium, and so blood is collecting right underneath the externa there, or the adventitia, and so we can get a little bulge there. And that's called a pseudoaneurysm, and they usually have a very high risk of rupturing, obviously because it's dealing with a high pressure and not as many layers to contain it. Now, in terms of the aneurysms, they can occur, multiple sites, not just the aorta. I mean, obviously, you can have them in cerebral vasculature and other peripheral arteries. But in terms of the aorta, you can have it on the ascending portion of the aorta as it's exiting from the heart, the descending portion of the thoracic aorta, or the most common, which is an abdominal aorta. So that's over here. Let me change that to red. This is the abdominal aorta. The abdominal aortic aneurysm is the most common, and that typically is somewhere between where the renal arteries branch and before the bifurcation of the iliacs. So now there's a couple things that can lead to an aneurysm. All right, or there are predisposing factors. For example, smoking is a predisposing factor. And in point of fact, if somebody has a history of smoking and they're between the ages of, say, 65 and 75 years old, then they should actually get screened for aneurysm, particularly an abdominal aortic aneurysm, because there's a high predisposing factor with smoking. It can be a family history of aneurysms and hypertension. Okay, so the increased pressure and stress along the walls can cause dilatation as well, particularly at junction points where there's usually some weakness in the endothelium there. Now, things that separates, say, certain aneurysms from let's say, the ascending versus the descending would be some of the ways in which the pathophysiology comes about. So, for example, cystic medial degeneration is found in the ascending portion of the aorta, and what that really means is you have sort of a loss of functional collagen and elastin fibers with maybe some replacement with some mucoid material, and it overall weakens the wall so that it can expand like that. and that's more common for, say, the ascending portion. It's something you might see in a connective tissue disorder like Marfan's or Ehlers-Danlos syndrome. Atherosclerosis, on the other hand, is probably one of the more common causes. Okay, and this is something I went into more detail in the ischemic lecture. Now, with atherosclerosis, you can obviously get weakening of the endothelium and so on, and weakening of the blood vessel wall over time. And this is very common for descending, so descending thoracic as well as in the abdominal aorta. In terms of risk of rupture, because that's what we worry about. As it starts to dilate, we're worried that it's going to actually break eventually, right? So the risk increases with size, which is sort of intuitive. So just a couple stats here. So mean growth is typically from about 0.1 to 0.4 centimeters per year. Okay, that's the average growth of aneurysms. Now, the thoracic aneurysm, what I have here is 2% annual rupture rate if the aneurysm is less than 5 centimeters in diameter. If it's and it goes up to 7% if it's greater than 6 centimeters. So this is just showing you the correlation between the size, that the risk gets greater as the size increases. If we're talking about abdominal, so abdominal aneurysm or aortic aneurysm, you can see 0.3% is if it's less than 4 centimeters, which jumps to 6.5% if it's somewhere between 5 and 6 centimeters. All right. Now, this helps us to actually dictate, what we're going to do for them clinically in terms of medically manage, follow them, or have surgical intervention. But just you have to keep in mind that despite this, increased risk of rupture with size, that also means that even small aneurysms can rupture. So that's important to understand. Okay, so in terms of presentation for aneurysms, most of them are actually asymptomatic and are found incidentally for workup for something else, or upon imaging they happen to find them. You could on an examination find a pulsatile mass like in an abdominal aortic aneurysm, or they may have symptoms based on focal compression. As the aneurysm grows, it compresses on the adjacent structures. Like for example, if you have an aneurysm, a large aortic aneurysm in the thorax, it could be compressing nearby structures like the trachea, the bronchi, causing respiratory issues, or on the esophagus, causing dysphagia. Diagnosis is usually done with imaging like CT with contrast, MRI, ultrasound. Now, in terms of ultrasound versus CT and so on, they're both 100% sensitive. And really, the ultrasound is probably the test of choice for detection. So, for example, if you're doing a physical exam, you happen to feel a pulsatile mass in the abdomen, you can get an ultrasound at that point to examine it further, and it has a great sensitivity and it's great for detection. If the patient's hemodynamically stable, all right, then you can do the CT, and the CT is also very sensitive. And this would be even better for, say, preoperative planning. So you get, better imaging quality and get, a little bit more specific about, how big it is and so on. And, that helps with the, operative planning. Now, the treatment is based on the size and the medical condition of the patient, right? So, for example, if they're hemodynamically stable and the aneurysms are fairly small, then the general practice is to do repeat imaging and make sure you manage their risks. So for example, some of the risks I mentioned previously were things like hypertension, so beta blockers and ACE inhibitors, ones that vasodilate and reduce wall stress. These will be vital for patients with aneurysms. Okay, so to lower that blood pressure. Smoking is another major risk factor, so counseling on smoking cessation. If they have hyperlipidemia, and since many are caused by atherosclerosis, then it would be, a good idea to start them on maybe a statin or something of that nature to reduce that risk, and aspirins and so on. Stuff that we talked about actually in the ischemia lecture. Now, in terms of surgery, so if they meet the qualifications for surgery, it's really based on studies that were done that demonstrate that at certain sizes, the risk jumps pretty significantly, more significantly than if it were to just be followed, okay? Or more significant than undergoing, or the risk would be more significant than undergoing, say, surgery itself. So they found in the thorax, the ascending thoracic aortic aneurysm, which is ATA there, if it's greater than 5.5 to about 6 centimeters. In the descending thoracic aortic aneurysm, about 6.5 to 7 centimeters. And in an abdominal aortic aneurysm, greater than 5.5 centimeters. Okay, so that's really kind of a criteria for saying, the risk is now pretty significant and warrants surgery. But you also have to take into account any underlying conditions your patient may have. So for example, if the patient has a connective tissue disorder like Marfan's, then they might opt to do surgery before it's gotten to a certain size to avoid higher risk in that patient at larger sizes. Now, there are other reasons they might do surgery if they don't quite meet that size criteria. So for example, a smaller aneurysm that's enlarging very rapidly. Okay, so I put down here about one centimeter per year. All right. Now, in terms of the surgery itself, you have really these two options, which I'm showing you here and here, where you actually have open surgery, where you can see in panel A there, it's cut open. Of course, it's clamped on either end, and then they put in this fabric sleeve. All right. Or you have an endovascular aortic aneurysm repair, where they actually put in a catheter, and that opens up a stent at the spot of the aneurysm to help reinforce it there. All right. Now, of course, these are major surgeries, and if you're going to do something like an open surgery, for example, you can't just clamp off the aorta and hope for the best in terms of circulation while this patient is undergoing this procedure. So oftentimes, what you're going to see or hear about is going to be something called a cardiopulmonary bypass machine, which actually helps to move blood from the venous side to the arterial side, bypassing the area where you'll be, undergoing the surgery. So I just specifically want to talk about a few of the features of abdominal aortic aneurysm, simply because it is the most common. It's usually asymptomatic, but if there are some signs or symptoms of it, they might have a sense of what we call fullness. If they have any kind of pain from it, it's usually located in the back or in the hypogastrium region, and it's usually described as like a throbbing type pain. And then some symptoms of expansion and impending rupture. So these are things to kind of be aware of. All right. So if it's expanding or it's possibly rupturing, you could have sudden onset of severe pain in the lower back, lower abdomen. It could radiate to the groin, the buttocks, or the legs. Okay. And then you'll see this image over here. You can take a look here. That's my arrow. So you have gray Turner sign. So a gray Turner sign is actually this bruising or ecchymosis on the back and the flanks, which you see right here. Okay. And then this over here, right around the umbilicus, is the colon. And that's bruising around the umbilicus there. And so this is actually can be a sign of retroperitoneal bleeding, since that's where the aorta is located. But however, neither is actually sensitive for the rupture of the abdominal aortic aneurysm, but it's something to keep in mind, especially on a physical exam with other clinical suspicion. Now, however, there's something we call the triad, a rupture of the AAA triad, which I put in bold there. So that would be abdominal pain, hypotension, okay, because you're losing blood, and a palpable pulsatile abdominal mass. So if you meet all three of those criteria, that's the triad. That automatically warrants emergent laparotomy, and so that means an incision in the abdomen and then taking a look, for surgical procedure. So and it would it doesn't require any further workup at that point. Now a couple things to keep in mind though: if it does rupture, you might expect to see something like syncope due to a drop in flow, and drop in volume as well as nausea and vomiting. Okay, so aortic dissection. So we're going to move on now, and dissection by definition is actually a tear in the intima. Remember the intima is the innermost layer. Now there's a tear there, and what happens is the blood then can move into the media, and it can spread through the media, actually in a sense peeling the intima away from the media and sort of creating what we call a false lumen. Okay, since it's no longer a part of the actual lumen, the true lumen. And some of the predisposing factors would be hypertension. I underline that one because that's the major one. All right, because that can cause weakening in the endothelium and eventually a tear. And if high enough pressures are there, it can actually push the blood right into the media. Connective tissue disorders, some of the ones I've already mentioned, like Marfan's, for example. Any kind of trauma, coarctation of the aorta, where you actually have a stricture in the aorta, creates a high resistance, high shear stress area. Points of atherosclerosis, again, because you're weakening the media there, and I'll discuss that in a different lecture. Now, in terms of the typing of dissections, we actually divide them based on a Stanford criteria. One's called type A, and type A dissection means it's in the ascending portion of the aorta, and it's the most common type and also the most dangerous type, versus type B, which is in the descending thoracic. And in fact, if you take a look over at the cartoon here, I'll show you. So here is type A, and you'll see there's two visualizations of that. And you'll notice that if it's involving the ascending at all, whether it's just the ascending or the ascending and the descending, we'll still call it a type A because by definition it's type A if the ascending is involved at all. If on the other hand it's just the descending, it's not involving the ascending at all, we refer to this as a type B, and it affects medical management, which is why we want to know. Okay. Now, in terms of presentation, they can be, most common it's sudden. All right, they usually have sudden, severe pain, and it's usually like a tearing or ripping quality type pain. And that tearing or ripping can be anterior or posterior, so posterior between the shoulder blades, or anterior like substernally. And that also gives an indication of a type A versus a type B. So, for example, if they have an anterior type chest pain, that's more like a type A. Whereas type B, which is descending, which goes again posteriorly, that's going to be more of a type B, which is going to be posterior between the shoulder blades. Hypertension is a common finding, but it's not always there. Lost pulses. Now, lost pulses really has to do with a complication that occurs with dissections, which is basically this. If you look at this cartoon, you'll see the false lumen there, which has a sort of a darker reddish color, let's say an A, so you can see here. You can see the sort of darker lumen there. The problem with this is that let's say we start to peel away the intima from the media and we create this false lumen and it starts to spread, like we're kind of shearing it off. What happens when we get to a junction where there's actually a branch point for other arteries, like you see here at the top of the arch, for example? Well, if we get to those points, we could actually have the intima tear from there as well, and the tear, the creation of the false lumen, could actually obscure or completely block that particular vessel. And that's where it becomes very, very dangerous. So that again, that could obscure or block, aortic branch vessels. So, on the arch or anything in the descending, or if it's in the abdominal, it could be renal and so on. On the ascending portion of the aorta, if we were to actually move retrogradely towards the heart, then we can have further complications from that, which I'll discuss in just a minute. So this is how we'd get differences in blood pressures in the limbs. Okay, so you have somebody who's like high blood pressure, but you may detect it in one arm, the other arm it's hard to detect any any kind of blood pressure because it's being obscured. So the brachiocephalic trunk, for example, is being obscured, so the right arm is very low blood pressure. It could cause aortic regurg because if, let's say, on the ascending portion of the aorta, it starts to move retrogradely down, that false lumen then could actually affect the annulus of the aorta, and you get regurgitation. If it affects the pericardium that surrounds the heart, then you can end up with tamponade as it bleeds into that space around the heart. On the other hand, it could affect the opening to the coronary arteries and obscure those, causing ischemia of the heart. And so it would present like a myocardial infarction. And so those are some of the ones that I've listed here. So, you can get a rupture, which of course is something we're concerned about, rupture and then bleeding, right, hemorrhaging. Occlude the branches of the aorta, which include some of the coronaries, right? So you can get an MI, tamponade, distortion of the aortic annulus, and of course any of the other vessels along the aorta there. Okay, so for diagnosis and treatment, CT angio, or otherwise known as a CTA, is very helpful. In fact, this first image that you see over here This is a CT, and you can see the aorta here has contrast in it. All right, so this would be this is the arch right here, and you'll see these labels over here. So the T stands for true, to label the true lumen. Then the I stands for intima, and the F stands for false lumen. So remember, the false lumen is really the space between the intima and the media, where the blood is actually accumulating. And you can see that it's actually, you can see that the intima is actually being pushed away from the wall there and into the true lumen there, and it can cause obstruction. Okay, and if it hits any kind of branch point, that could cause a problem. You also may note that you're seeing this particular feature here starts really on the descending portion of the aorta, so this would be like a type B dissection. So these are useful because you can see it, and you can see the extent of it. Okay, and it's good for surgical preoperative planning. Now, most emergency rooms will have a CT available, and it can be done quickly, so it's very useful for that. However, if let's say our patient is very unstable and we need to do something bedside, we could opt for something like transesophageal echo. And so that can be done bedside and also very, very good. MRA, so when we talk about MRI, these actually take longer to do and are usually less ideal in an emergent situation. But it will definitely give you good anatomic definition. Contrast angio was the standard at one point, but since imaging has improved, we use usually other modalities. Chest x-ray. With a chest x-ray, since those are usually done frequently when the patient comes into the emergency room, you can see one over here, that's anterior to posterior. There's a widened mediastinum, and so that can be an indication of several things, but given the clinical picture and seeing the wide mediastinum, it's very suggestive of the dissection. In terms of treatment, all right, so if we're diagnosing this as a dissection and we want to label it as type A, type B based on our imaging and so on and our workup, the first thing we want to do is make sure we lower that blood pressure, because that's one of the major risk factors. And if you guys recall, I discussed this in my blood pressure video lecture. We want to drop that blood pressure to less than 120, so typically between 100 and 120 millimeters of mercury systolic. So that means we're going to give them, IV vasodilators, sodium nitroprusside, beta blockers are useful. This, again, lowers that pressure, lowers that shear stress, and prevents more tearing. And if it's type A is surgical. All right, so that means we're either going to suture or use a graft, okay, to help close that off. This will be done with type A because type A has a very high mortality without any intervention at all. And like I said before, it can cause severe complications in the heart because it's so close to the heart. You can get acute regurgitations of the aorta, tamponade, which can compress the heart, can cause an MI. And I should point out here, actually, in a type A, since they can present with anterior chest pain, okay, and since it can cause an MI, you could actually see elevated troponins, for example, and it causes ischemia to the heart, and an ECG would show ischemia in the heart as well. If this is worked up as, say, an MI, and the person is then given anticoagulants or a thrombolytic, that could actually prove deadly in this case if they were missing a type A dissection because of the bleeding. Okay, so you have to be very, very careful with that. Type B, this requires aggressive medical treatment, not surgical. So it's medical. Basically, we're going to optimize them medically. However, if they have, say, unrelenting symptoms that aren't recovered with the optimal medical treatment, then they may require surgery. Or if it progresses, or if they think that there's a major artery that might be affected by this, then they may opt for surgery. So that'll be on sort of a case-by-case basis. Okay, so now we're going to move on to the peripheral arterial disease, PAD. This is an occlusive type disease. So an occlusive atherosclerotic disease of the lower extremities. All right. Now, if you recall my ischemic lecture video, I talked about how occlusion of the coronary arteries, how that led to ischemia downstream of the heart muscle. This is essentially the same effect, but instead of talking about it in terms of the heart, we're talking about it in terms of the extremities. Okay, and the lower extremities are very prone to this. So, but it's the same general principle. In fact, I even have listed here supply and demand, if you recall that from my previous lecture. Okay, there's a mismatch between supply and demand. So that's why I say it's similar to coronary artery disease. There's disrupted endothelium, which was sort of the underlying pathology that we found with atherosclerosis. There's oftentimes, since if they have atherosclerosis of their peripheral arteries, that's causing disruption of flow. This is often coexisting with atherosclerosis elsewhere, and those common sites would be things like in the coronaries. So they might have a prior myocardial infarction, congestive heart failure from it. They may have a history of diabetes or lung disease and so on. So this, oftentimes if this is discovered, it's usually coexisting with these other ailments. The risk factors are the same that we've talked about with atherosclerosis, so smoking, hypertension, hyperlipidemia, diabetes. So you can kind of think about now, in terms of the treatment, because it's basically the similar idea. Now, the most common sites for this to occur are in the superficial femoral artery, the popliteal artery, and the aortoiliac region, so which can cause occlusive diseases there. So those are the most common sites. Now you can imagine if, for example, you had an occlusion of, say, the femoral artery or the popliteal artery, downstream of that would be affected and become ischemic, and that would be presented as, say, pain, for example. Oftentimes with those two arteries, you get ischemia and pain within the calves, okay, or the gastrocnemius muscles. If it's aortoiliac, so it's higher up, any occlusion there would affect structures higher up than that. So that would be in the calves as well, but would then might be also affecting, the buttocks, the hip region, and so on. Now, in terms of supply and demand, just like with angina or anginal pain, all right, there can be intermittent pain. So, for example, the person's used to walking, let's say, 5 or 6 blocks every day, and they notice that as they're walking 5 or 6 blocks, by the time they reach, the 5th or 6th block, their legs are starting to be in a lot of pain, and that's due to this buildup of ischemia. So there's a poor supply for that demand. There's a poorer prognosis if it's occurring at rest, just like we saw with the heart, right? And then the ulcers can form. So what happens is we want to make sure that under normal physiological conditions, if the demand goes up, the supply is matched accordingly, and that keeps all the tissues happy. However, if it's not met, demand is not met, and let's say they're getting pain at rest, they're at risk of ulcers because under resting conditions, they're not perfusing adequately, and poor perfusion means not only a lack of oxygen and nutrients, but also the ability to fight off infections as readily and repair tissues. So damaged tissue then it doesn't repair as easily and can become a nidus for infection. So you have to watch out, and they could be at risk for gangrene. All right, and that's a major risk, especially in terms of diabetic patients. This is very prevalent. Okay, but it does also over time can also affect the nervous system. And so they can have a loss of sensation there, and they may not realize it when they actually do damage their tissue. So some of those signs and symptoms, we call this intermittent pain that goes away with rest, we call that claudication when it occurs in the limbs. Okay, but it's got the same kind of principle as coronary artery disease. So this exertional pain, all right, loss of pulses because you're reducing the flow downstream, so they may have reduced pulses in their say their ankle. They could have bruits, right? So you could listen to murmurs going past a constricted area of the artery. Now, oftentimes, since the blood is not being able to reach the tissue adequately, they could have pallor, right? So it would look kind of pale. So lack of blood flow. It would feel cool. So this is important. It would feel cool to the touch because they're not getting that good flow of warm blood. It could appear cyanotic because it is getting a little blood and extracting a lot of oxygen from it because the demand is so high. So it could turn kind of bluish. And often the tissue, that area that's being fed by that blood, can actually start to atrophy. So the muscle itself can atrophy. They could have hair loss. So hair loss you have to look for. Right? The skin looks smooth. They may lose their sweat glands there as well. All right. And I mentioned already there's an increased risk for things like gangrene and necrosis and cell death, especially since it's damaging nerves. The tissue doesn't heal as well. You're not getting as many white blood cells in there to help fight off infections. And one last thing I want to mention is that they can often have prominent pain at night. Now this is really kind of because it's kind of gravitationally driven. So if we stand up, that helps to drive arterial blood towards those lower extremities. Okay, so oftentimes it circulates a little bit better when they're standing with the help of gravity. At night, when they lay flat, they no longer have the assistance of gravity, and so what ends up happening is flow can diminish even further, and that can cause further ischemia and pain. They may mention something like hanging their feet off the end of the bed when they sleep just to, help with the circulation. Okay, so in terms of diagnosis, now the physical exam actually gives us a good indication of how healthy this patient is and how healthy their arteries are, because on the physical exam, you can listen for bruits, all right? You can feel the extremity if it's cold or not, whether it's hairless, okay, it's lost the hair, and you can feel for the pulses and feel if they're diminished. So it gives you a lot of information about the health already. Now to make that, to make a diagnosis in terms of its severity, we would use something called an ankle to brachial index. And this is where we compare the blood pressure in the ankle, so say the dorsalis pedis or the posterior tibial artery, and we divide that by the blood pressure in the brachial artery, which is in the arms. Okay. Now the normal range is between 0.9 and 1.3. So let me explain something quickly in terms of normal physiology. If the person is upright, the blood pressure in the legs is higher than the blood pressure in the arms. Okay. So that means that the ratio would tend to be above 1. Okay. On the other hand, if I had the patient lie completely flat, and we're assuming right now normal, healthy, patent arteries. If I have them lie flat, the blood pressures would equalize. It would be the same in the legs as in the upper extremities, and the ratio would be 1. Now, let's say somebody has atherosclerotic disease of the popliteal artery, so there's diminished flow going to the ankle. That means I'm going to have a diminished blood pressure in the ankle as well. So what happens is the ankle blood pressure, as that goes down, all right, it can become less than the upper extremity when the person's upright. All right, so it can be diminished. And even as they lie flat, it would be even further diminished. Okay, so what happens is it switches the physiology. The lower extremities actually have lower pressure than the upper extremities, and so the ratio goes down. Okay, so the ratio goes down. Now, if it goes less than 0.9, all right, 0.9, that's indicative of some form of peripheral arterial disease. The lower it goes, the more severe it is. In fact, they may become symptomatic as it goes below 0.7 and so on. Okay. Now, an arteriography is actually an imaging way of actually looking at and locating where the peripheral arterial disease actually is. So you might have a good idea based on the physical exam, but this could locate all the spots very clearly and is the gold standard for the diagnosis. And that's what you're seeing over here. So this is normal in A, and then B over here. If you look at it by comparison, you can see all the spots where there's halt in blood flow and obstruction. Okay, so you can just compare the two there, and this gives a good idea of how severe it is. Okay, put that into tie that in with the clinical picture. Now, in terms of treatment for this, it follows very similar to coronary artery disease in that put them on an antiplatelet because this is primarily caused by atherosclerosis, right? So aspirin and clopidogrel, assuming no contraindications. Now, an ACE inhibitor may reduce symptoms. It's a little controversial with ACE inhibitors. They may reduce symptoms in some cases. However, for the most part, vasodilators don't really have any effect here. This is where we differ greatly from what happens in the heart. Vasodilators for the heart are really great because it can, reduce afterload and so on, and reduce preload and help out the heart and reduce its demand. However, when it comes to peripheral arteries and getting flow down to those lower extremities, like the toes, for example, which have like the smallest arteries, vasodilators actually don't do a whole lot. And in fact, one of the thoughts behind it is that as you vasodilate, remember that atherosclerosis is occurring just underneath the intima there. And you're vasodilating the media, which is just outside of it. So as that vasodilates, the stricture is still there. So they found, little evidence that vasodilators really help. Now, that doesn't mean you wouldn't use a vasodilator to help with other things in terms of their hypertension and so on. Risk modification is going to be huge. You're definitely going to want to make sure you counsel them on smoking cessation, since that is a major contributor to PAD. Okay, as well as making sure that they have good glucose control in case they're diabetic and so on. Exercise if they're obese. High blood pressure would help with exercise, or exercise would help with high blood pressure as well. Supportive care of the feet. So they could lose sensation, right? And so if they lose sensation in their feet, if they step on something sharp, or they get kind of cuts or abrasions, or even step on glass, for example, they have a hard time repairing, and it could become infected. So they have to make sure they're aware to check their feet several times a day. They got to avoid the extremes of temperature, because colder temperatures are going to cause more vasoconstriction, and that could actually worsen the flow to those areas. Now, in terms of overall help and the medication that's going to work the best for claudication, for example, is cilostazol. Cilostazol is going to be essentially your drug of choice here. It's a phosphodiesterase inhibitor, and it has a twofold effect. It actually inhibits platelet activation and causes vasodilation, and has shown to be one of the more useful drugs for this condition. Pentoxifylline is another drug that has sort of mixed results. May aid in deformability of red blood cells to help them kind of squeeze through narrow vessels, but overall seems to be better in theory than in practice. Revascularization is another option. So you can do angioplasty and break open those areas, and you can stent them. You can do bypass. Again, this would be depending on how severe it is and how much tissue is at risk. And ultimately, amputation in certain circumstances where there's really very little salvageable tissue, and they're at risk for gangrene and so on, and or they may already have gangrene. So this is probably the most common thing to see in diabetics, or most commonly seen in diabetics. All right, so before we were talking about really restriction of blood flow to an area, and now we're going to talk about if we actually just occlude the flow to an area. All right. Now, the most common causes of a complete occlusion in the arteries is actually going to be from the heart. So AFib, or atrial fibrillation, accounts for 85% of the causes of arterial occlusion. So in a workup with a patient with any kind of an occlusion or an embolus or a thrombus formation, a heart examination is necessary. All right, that could include things like endocarditis, so some infection on the valve that has broken free, so septic emboli, some post-myocardial infarction sequelae. It could be due to atheromatous material. So you may have an atheroma that's forming that has broken off a piece of it. We call that an atheroembolism. It could be due to an aneurysm. The aneurysms themselves can cause some stasis of blood flow there and be procoagulant. Or it could actually come from the venous side. We call that a paradoxical embolism. So if you recall, typically with an embolism on the venous side, when it travels to the heart, by the time it gets to the heart, it usually gets wedged in the pulmonary circulation and doesn't leave there. And that can cause something like a pulmonary embolism, which I'll discuss shortly. However, there are occasions, and I've talked about this in the congenital abnormalities lecture, where you can actually have an embolus move from the right side of the heart to the left side of the heart through a defect. Okay, so for example, like a patent foraminovalle. Now, the thrombus, you can have a thrombus form. Remember, thrombus is non-moving, so this could be due to atherosclerosis over time. It could occur, in the site of where a graft was placed, and or just an area of damaged endothelium in general. Okay, some of the ins and outs that I've discussed in other lectures. Now, the most common site is the common femoral artery. Is the most common site for an occlusion. Now, the signs and symptoms of this. So this patient comes in, let's say they have the common femoral artery has been occluded. It's really what they call the 6 Ps. All right, so there's pain, all right, and the pain is usually sudden and very severe. Okay, in fact, they usually can tell you when and where it happened. Okay, there's pallor. So it's pallor because you have lack of flow to that area, all right? It's cold, so we call that polar, all right? Or poikilothermia is also cold. Pulselessness, because there's no flow to that area, so the pulses are gone. Paralysis and paresthesia, so they can get some numbness and tingling to full-out paralysis, okay? So the little cartoon up here can kind of show you that. I also see that I put paralysis down there twice. I'm not trying to re-emphasize that at all. Just cross that out for you. All right. So you can see the same thing over here. Diagnosis and treatment. So an arteriogram, a CTA, all right. So versus an invasive angiogram. Basically, either one of these, an angiogram versus CTA is going to be clinical decision. It's going to help define where the site of the occlusion actually is, which is important for the procedures. You also want to do an ECG in your workup because, as I mentioned, 85% of what's going to cause this is actually coming from the heart, particularly atrial fibrillation. So you should get an ECG to take a look at the rhythm, check for any kind of an MI, get an echo done, look for a cardiac source of an emboli. So maybe the patient has, endocarditis on the valves. Maybe they formed a thrombus within an aneurysm in the heart. They may have a shunt, which would suggest maybe a paradoxical embolism from the venous side, and so on. In terms of the treatment goal is to basically assess viability of the tissue, all right, to salvage the limb. Same idea as when you want to salvage any heart tissue, all right. You don't want to undergo any risky procedure if there's nothing to salvage. So we make sure is viability of tissue. And just so we understand, this is different from heart muscle that dies very quickly. Skeletal muscle, on the other hand, can tolerate 6 hours of ischemia. So usually, this, procedures should be done within that window. Okay. Anticoagulate. So heparin. Again, the choice of heparins are going to vary based on some outcomes in terms of bleeding more with some versus another. But you're going to use heparin, either unfractionated or low molecular weight heparins, and then ultimately you're going to bridge them as they leave. You have to bridge them to something that they have to take chronically. So for example, warfarin is a common one. So you start them on heparin, make sure they're therapeutic, then give warfarin, and keep them on heparin and warfarin at the same time until the warfarin becomes therapeutic. You want to check things like INRs, for example, and have an INR between 2 and 3. And once they've reached the therapeutic range, you can take off the heparin, and then they can go home taking the prescribed dose of warfarin. Revascularization, so obviously we still have the clot. That was just anticoagulation, right? So we still have the clot there that we have to deal with. So we have to revascularize. So you can do a bypass surgery as an option, thrombectomy or an embolectomy, where you actually go in there and remove the clot itself, or thrombolysis, where we're actually going to inject into tissue plasminogen activator to break down that existing clot. So that's what's going to help reperfuse. Now, amputation is a possibility. Again, that's based on the assessment of vital tissue. Because if the tissue is no longer vital due to lack of flow for a prolonged period of time, it becomes more of a nidus for infection and other complications. So amputation becomes a possibility. All right. In fact, in terms of the thrombectomy and embolectomy, so draw your attention to the cartoon over here. You can actually, in certain cases, just insert a catheter into the blood vessel, and you can see the clot right here, and this is called a Fogarty catheter, and it's pushed past the position of the clot itself, and then the balloon is inflated. So that's the Fogarty balloon. So it's inflated, and then the catheter is actually pulled out, and you can see as it's being pulled out, you see the arrow there, it's being pulled out, it actually takes the clot with it. So they have some pretty clever mechanisms for being able to handle this. Okay, so what I'd like to do now is just touch on what we call the vasculitic syndrome, and I just want to touch on a couple ones that are well known, and to give you guys an idea of what occurs in certain conditions where there's inflammation of the arteries. And this is just kind of bulleting some of the major points for all of them, where you have vessel wall inflammation. Okay, and this is usually from an immune complex deposition or a cell-mediated reaction against the vessel wall. Okay. This ends up resulting in increased vascular permeability, okay, so things like swelling and so on, release of lysosomal content, so this can release oxygen-free radicals, which is very damaging, and it can ultimately lead to disruption of the endothelium. And disruption of the endothelium, as you know, is going to lead to things like thrombosis, necrosis, and death. And this can, as complications of this, can cause obstruction of arterial blood flow. And we already discussed what obstruction can do to the peripheral tissue. Okay, so the first of the vasculitic syndrome I want to talk about is Takayasu arteritis. So this is a chronic condition. All right, it typically affects the larger arteries like the aorta and its branches. Primarily affects Asian and African women between the ages of 10 and 40. And they have focal symptoms that are related to the affected vessels. And so, as I've kind of drawn over here in red already, you can see this right here is the aortic arch and its branches. So this first branch here is the brachiocephalic trunk. You have the left common right here, and then this would be the left subclavian artery. All right. And you'll notice if you look closely here, you can see these dilatations that are circled, all right, where there's inflammation occurring. And so, if you get inflammation, scarring, and even constriction of those areas, what can happen is, let's say, for example, a patient has constriction of the left subclavian artery. As that constriction flows to that left extremity, you can see things like pallor and loss of pulses, for example. And in fact, this disease is often referred to as the pulseless disease because if it affects multiple of those vessels, like the right and left subclavian as well as the carotids, you wouldn't be able to feel any of these pulses. Okay, so that would also affect any of the downstream tissues that are being fed by those arteries, like the brain and the extremities. Histo and immuno for this you'd find anti-endothelial antibodies as well as multinucleated giant cells. And in terms of the treatment for this, steroids to reduce the immune response, cytotoxic drugs, surgical bypass in certain cases. Another of the vasculitic syndromes is called giant cell arteritis, as well, also known as temporal arteritis. This is also chronic, but this affects more the medium to large arteries, which can include things like the aortic arch and its branches, as well as oftentimes these cranial vessels. All right, so this would occur in typically females over the age of 50. Histology would show multinucleated giant cell if we were to take a biopsy. Okay. Temporal and facial artery involvement is common. Okay, is common. And so what that can do is that can actually cause things like jaw claudication, because that's what these vessels are feeding. Jaw claudication, diminished temporal pulses, impaired vision if it involves the ophthalmic artery. Diagnosis involves a workup of taking an ESR and a CRP, which are inflammatory markers, ultrasound, and biopsy. As I mentioned before, the biopsy will help confirm the diagnosis. So, for example, in the picture that you see over here, I have the arrow drawn pointing towards the temporal artery. And so, if they biopsy the temporal artery, see the giant multinucleated cells, and an elevated CRP would make our diagnosis. The treatment is high-dose steroids, and it usually has a very limited course overall. All right, so the last vasculitic syndrome I want to talk about is Thromboangiitis Obliterans, otherwise known as Berger's disease. So this one actually affects the medium to small arteries, as well as it can affect veins and nerves. And it occurs in like a sort of segmental fashion of inflammation. And it has sort of very, very specific findings. So for example, this is generally found in patients who are male, under the age of 45, Middle Eastern, and cigarette smokers. Okay? I underline cigarette smoking because that seems to be the trigger, and they're usually associated with what we call human leukocyte antigen, or HLA, A9, and B5. All right, and so that's what this cartoon over here is showing you in these distal extremities, like in the fingers and toes. You can actually have tissue that becomes ischemic or even necrotic from just severe constriction secondary to the cigarette smoking. And there's a triad of symptoms, right? They have distal artery occlusion, all right, which can result in pain and pallor and so on. Reynaud type phenomenon, which I'll discuss what Raynaud's is in the next slide, but it's a type of vasospasm. And then migraine superficial venous thrombophlebitis, which I'll discuss, in the venous portion of this lecture. All right. But that would cause, inflammation, constriction of venous flow and decreased venous return, which can cause swelling and so on. There's generally a lack of atherosclerosis in these patients, and the treatment is fairly straightforward. It's cessation of smoking. So you have to offer smoking cessation counseling. All right, so in terms of vasospasm, we have what we call Raynaud's phenomenon. This is not a vasculitic syndrome. This is separate from that. What you have is digital artery, so in the fingers, artery spasm. All right, so this can occur in the fingers and toes. And you can see in the circle here, you see that pallorus region in those three fingers there, where you can actually get such severe vasospasms, it completely restricts flow to that area. And in fact, it can cause what we call a triphasic color response. In fact, as it starts to constrict and reduces blood flow, and that ischemic tissue starts to draw off more oxygen, it causes cyanosis. So it can turn blue initially, and then as it completely closes off flow to that area, it becomes pallorus. Okay, as we've seen with any kind of occlusion in the arterial system. And then finally, as flow resumes again, you have redness. So it goes from blue to white to red. Things that can cause that are things like cool temperatures, because normally, physiologically, our distal vessels will actually constrict in response to cold temperatures to help shunt warm blood to the more vital organs. Emotional stress causes a sympathetic output. That sympathetic output can activate those vessels. Understand that those distal small vessels in your fingers and toes primarily have just alpha adrenergic receptors, alpha 1. So this primarily causes vasoconstriction of those areas. Now, this is often associated with pain and paresthesia, or numbness and tingling. Okay, there's two really types. We have a primary Raynaud's disease. This usually occurs in women between the ages of 20 and 40. And this is really just an exaggerated sympathetic response, where it's overly sensitive to the sympathetic drive, so it activates them very vigorously. And or included in that would be the endothelium itself releasing too much or over-releasing endothelin 1. I discussed this endothelin 1 in a separate lecture, but just as a reminder, endothelin 1 actually triggers smooth muscle constriction. So the combination of sympathetics, overdrive or sensitivity, and excess endothelin 1 activation can cause severe constriction and vasospasm of those areas. Secondary Raynaud's phenomenon is actually secondary to something else. Okay, so for example, scleroderma, SLE is systemic lupus erythematosus. All right, where you have essentially a disrupted endothelium, which causes excessive vasoconstriction, which I spoke about. How disrupting the endothelium causes typically excess vasoconstriction. In terms of the treatment, some of the things can be straightforward, like avoiding the cold, dressing in warm clothes and dressing appropriately for it. You might want to add calcium channel blockers. Again, calcium channel blockers will prevent them from smooth muscle from constricting as well. Alpha adrenergic blockers, again, since there's primarily just alpha 1 receptors there, this might help to keep them dilated. Phosphodiesterase type 5 inhibitors will also help to increase vasodilation in that area. So these are all aimed at reducing the spasm and have some beneficial effect. Okay, so now let's talk about the venous system. And to start, we'll talk about varicose veins and chronic venous insufficiency, or CVI. With varicose veins, what you have is essentially a dilated, tortuous, superficial vessels. So a couple things to keep in mind in terms of the physiology is that the venous system is a much lower pressure system than the arterial system. This is draining blood from the tissue. So the tissues essentially have already received its oxygen and nutrients, and the venous blood is now returning with lower oxygen tension, carrying waste and so on, and distributing that back to the heart. Now, there's generally more veins than there are arteries. Okay, so there's more essentially tributaries and pathways for the venous blood to travel, but it requires things like skeletal muscle pumps and one-way valves to help move it against gravity. Okay, because it is a lower pressure system. Now, in some cases, the veins may become dilated and tortuous. Okay, and usually affects the lower extremities. So you can see some of the varicose veins in the patient over here. Okay, see some over here as well, right? Generally occurs more in women than in men, and there can be a family history for this. Often affects things like the saphenous vein and their tributaries, because it's usually this is like a longer vein with fewer valves, so there can be more pooling that can occur there, more distension of the veins. However, if you have pooling and backed up veins and they become tortuous and twisted like that, if it occurs in the anorectal region, which that's referred to as hemorrhoids. If it occurs in the lower esophageal region, that could be esophageal varices. All right. If it occurs in the spermatic cord, it's called a varicocele. But it's essentially the same idea. These are, varicose veins. These are dilated veins, and that can be due to the fact that there is upstream increase in pressure. Okay, either due to the fact that, let's say, the liver is scarred, and so venous blood's not able to move through the liver as readily. That can back it up into the veins. The veins can become distended from that. Okay. It could be due to the fact that somebody has, a thrombus, which has occluded some of the vein, and that causes backup of flow and distension. So we can have what we call a primary, primary type, which is really just occurs in the superficial veins. The superficial veins are the ones that you can see on the surface. All right, they're the ones that are noted in the skin, and then you have the deeper veins, which it communicates with. All right. Now with primary, these are really the superficial veins. The superficial veins, things like standing, pregnancy, obesity, right? So prolonged standing, a lot of gravitational pull causes pooling of the blood in those veins. Pregnancy, which is volume overload, as well as an increase in resistance through the abdomen there, can also cause that. Obesity can cause it as well, and one of the reasons for that, obesity can cause this sort of predisposition to varicose veins, is that the adipose tissue is not as good a structure at maintaining and holding the veins in place as, say, lean muscle. So that's one of the reasons for that. Secondary, it would be the deep veins are the cause. Keep in mind in physiology that you have the deep veins and the superficial veins, and they essentially run in parallel, and they connect to each other through these connecting veins, which you can see down here as an example here. So let's say this is one of our deep veins up here, and this is a superficial vein. They can communicate that way. Now, the way this communication works is that the superficial veins will drain into the deep veins, and they only drain towards the deep veins because we have one-way valves that keep them going, and that ultimately lead to a deeper vein. The deep veins do not communicate to the superficial veins. Or in other words, deep vein blood flow does not go to the superficial veins. It's superficial to deep only. So in superficial, we have some issue where there's backed up pressure, and the superficial veins, may lose the ability of those valves. Those one-way valves may start to open up and be stretched and distended, and now we get more pooling and a larger column of fluid. And in the secondary, there's maybe a thrombus, for example, which is one of the most common causes. There's some sort of blockage, and that causes backup in the deep vein, which can ultimately affect the superficial veins if it starts to back up and go through one of those connecting points that I've circled down there for you. In terms of symptoms and signs, generally there's, they may be asymptomatic, but there could be an ache or a heaviness to them. Some kind of a pressure they might feel. They might have, what's called a bruising in that area as blood is kind of, seeping out of there. The venous insufficiency oftentimes really just means that we're backing up blood so much that we're distending those valves that what ends up happening is the pressures start to build up, and then fluid extravasates into the tissue, and so you get swelling. All right, from that increase in hydrostatic pressure, for example. And over time, that blood that's moving into the tissue there, those vessels can become more permeable and stretched and distended, and damaged endothelium can lead to things like protein and red blood cells moving into the tissue space as well. And that can result in discoloration of the tissue, actually, if it's chronic. And in fact, that's what you're seeing over here. This is venous insufficiency. All right, so this is where the veins get distended, dilated, blood starts to seep out, and it can cause swelling. But if it's chronic enough, that protein and the red blood cells that contain the hemoglobin can ultimately essentially stain the tissue there and leave that kind of reddish brown color. The treatment here is going to be elevation. Okay, so you want to lift it up and help the veins to drain back to the heart. You want to avoid prolonged standing. Offer things like weight loss, so more lean tissue to help support the venous blood vessels. Excuse me. External compression socks that they would usually have to wear daily. Now, you may have to offer things like sclerotherapy, where they actually damage these little varicose veins to help kind of just close them off entirely. Thermal ablation can also work, and sometimes surgery, depending, again, if it's thrombosis and so on, they may require some surgery. Now, a couple key points to point out with the physical exam is that in this case, you would see, as I pointed out, if we have venous insufficiency, you'd see this in the legs with that sort of staining. Oftentimes, the extremities are warm, so that's why I put in this box up here. With chronic venous insufficiency, there's pooling in the veins, it's warm because the blood has reached that area, has reached the tissue and the capillaries, and it's pooling in that area, so it is warm, it's not cold. In PAD, oftentimes the extremity would be cold. All right, and another big difference is with venous insufficiency. Elevation of the legs above the level of the heart helps. Elevation of the legs above the level of the heart in arterial disease worsens the symptoms. Okay, so venous thromboembolism. So let's talk first about deep venous thrombosis, or DVT. Occurs commonly, or most commonly, in, say, the calf veins and those deep veins. 20 to 30% can propagate to the proximal vessels. And this coagulation is based on Virchow's triad. Okay, where there's stasis of blood flow. Okay, hypercoagulable state like factor V Leiden, for example. Or vascular damage, where there's disruption of the endothelium, which helps us to maintain homeostasis by preventing unwanted coagulation and clotting. So these are really the three that apply to both the arterial side and the venous side as well. Generally, women are higher risk if they're late in pregnancy or they're on an oral contraceptive. Anyone over the age of 60, malignancy is another one, prior history of a clot, hereditary hypercoagulable states like factor V Leiden, which I mentioned, congestive heart failure, obesity, trauma, and so on. There's many things that could predispose to this, including things like prolonged bed rest and so on. Now, in terms of its presentation, it does have a classic presentation, though you'll see that about half of them don't present with this classic presentation. So fever from the inflammation, unilateral leg swelling with edema, right? So it's edematous, localized warmth, erythema, so it turns red, and it's usually very tender. So if you see swollen, tender, and red leg, that's really your sort of classic presentation. About 50% will actually present with that classic presentation. They don't all, because let's say we obstruct the deep vein, but the deep vein still has patent superficial veins and so on. It might be able to redirect flow to other veins, in which case it doesn't readily swell and doesn't become all erythematous and so on, and there's less pain. So just because they don't have this doesn't mean, or they don't present like this, doesn't mean they don't have a thrombus there. There can be what we call a deep venous cord, which can be, what they call palpable, which just means that the vein itself is kind of hardened where the thrombus is, and you can actually feel it. Feels like a cord or something rigid. Homan's sign is not specific, but they always bring it up, and you cannot make a diagnosis with Homan's sign. But basically, what you're doing is you have the patient relax, and you forcefully dorsiflex their foot, which elicits pain. But as I said, it's not specific. The diagnosis to work this up is really your standards are going to be ultrasound. In fact, they do what they call a venous compression ultrasound, where they try to push down with the ultrasound transducer to see if they can collapse the vein. If there's a thrombus there, the vein doesn't collapse all that because it's being propped up by that thrombus, right? So that's sort of your initial test. And then a D-dimer. So a D-dimer, it's important to understand that a D-dimer, what that's doing is that's detecting the breakdown products of fibrin, okay? And that would be suggestive of something like a thrombus forming. However, it's not specific at all. It's very sensitive. So if the person has, let's say, a DVT, it would be elevated. So here, in this regard, DVT being sensitive but not specific simply just means that there are many things that can cause an elevation in the D dimer. And in fact, that's what I put in this circle over here. All right, so elevated D dimer, DIC, disseminated intravascular coagulation, heart failure, tumors is another big one. Infections can do that. So there's a host of things that can do that, which include a DVT or a PE, which is a pulmonary embolus. All right, can all elevate them. So if you see that it's elevated, it doesn't make the diagnosis. But if it's not elevated, it helps to rule it out. And so that's what's important about the D dimer. So if it's not elevated, all right, that can help to rule out the DVT. So usually in combination with the ultrasound and clinical suspicion, you can make the diagnosis. So for example, if the D dimer is elevated, and then you do the ultrasound, which tests positive, and you have clinical suspicion, then you have your diagnosis. All right. So in terms of the treatment for this, elevation can help with, again, returning of the venous blood flow. Anticoagulation. Okay, so it's going to be heparin followed by warfarin. Thrombolytics to help break down the clots. Prophylaxis following any kind of bed rest or surgery, for example. So if somebody just had surgery and they're going to be bedridden, you want to make sure you either ambulate early on, to make sure you move the blood in those veins, or give something like a pneumatic compression device, which they wrap around the calves, for example, and they fill up with air and compress. They basically take on the function of what the skeletal muscle would do otherwise, which is to milk the veins and help move the blood. Because, as I mentioned already, stasis is a major contributor to clotting. Now, before I move on from this, though, just a couple things in terms of its workup. In this box, if the person is Doppler positive, so you see, like, you think you see the thrombus there, you can't really compress the vein, then you're going to anticoagulate. If, on the other hand, it's iffy, it's non-diagnostic ultrasound, then you can have them follow up in a couple of days and repeat. If it's negative, there's no anticoagulation. Now you put that in conjunction with the D dimer and the clinical suspicion, that helps to make the diagnosis as to whether or not you should anticoagulate them then, or wait a little while and do repeat imaging. The pulmonary embolism is really a complication of a DVT, where thrombus form, breaks off, and then clots somewhere downstream, and it can occur in many different types of veins. And ultimately, as I've mentioned already, that can travel all the way to the right side of the heart, and barring any type of patent foraminal valley or something of that nature, it should go into the lung circulation. And depending on the size of it and the number of them and so on, that can cause mild to very severe diseases. So in the lung, what happens is if you get obstruction to flow in the lung, that can actually create dead space in the lung. And just as a reminder, the dead space means you're ventilating that area in the alveoli, but there's no blood flow going past the alveoli to undergo gas exchange. So it's a dead space. All right, so this will cause what we call a ventilation to perfusion mismatch. Now, you could have increased pulmonary vascular resistance because you have an obstruction there, which shoots the resistance up very, very high. And that high resistance translates backwards onto the right side of the heart. The right side of the heart is not used to high resistances because it's generally used to lower resistance pulmonary circulation. And so what can happen is that sudden increase in resistance can actually lead to right ventricular failure due to that sudden increase in pressure. Now, in terms of presentation, if it's blocking and causing dead space in the lungs, that can cause shortness of breath or dyspnea. You can have pleuritic chest pain, which means pain with breathing. Hemoptysis, because you may have rupture of some of the vessels due to the backed up blood flow. Cough, syncope due to reduced cardiac output. Bronchospasm. All right, tachypnea, so an elevated respiratory rate. Elevated pulmonary arterial pressures, and JVD, or jugular venous distension, as that pressure translates backwards and causes venous pooling. The diagnosis for this, you do an ECG. Now, to be clear, most of the time on an ECG with somebody with a pulmonary embolus, they're really just going to show tachycardia. That's the most common finding. However, they do find that, in a subset of patients, they have this very specific finding, which is referred to as an S1Q3T3. In other words, in lead 1, there's a prominent S wave. In lead 3, there's a Q wave and an inverted T wave. So that's where the S1Q3T3. There could also be right ventricular strain shown by, inverted T waves, for example, in V1 through V4. But again, the most common is going to be tachycardia. ABGs, again, to assess oxygenation status and pH as well. The CTA typically our spiral CT, which is very quick. This is really our preferred test, which I put in parentheses there for you. So that's what you're looking at over here. Okay, and so just to orient us a little bit here, all right, what you're looking at, I'll outline it here. This region right here, that is the pulmonic trunk. All right, so we have the left and right pulmonic arteries over here and here. And what I also want to point out for you is that this has contrast in it, so you can see the contrast is filling up that pulmonic trunk into the pulmonary arteries. And what happens if there is blockage there, if we have an embolus, inside the lumen of the vessel there, what happens is the contrast flows past it. It creates what we call a filling defect. Like, it doesn't fill up uniformly with contrast. It seems to create darker areas, or what looks like shadows almost, in the lumen. And that's what these little red arrows are pointing out here. You can see one right here. You can see more right there. Okay, these are filling defects. They're filling defects because the contrast is going around the clot. And so that would help us to localize and indicate, the size of the thrombus and so on. VQ scan is really just measuring ventilation to perfusion to measure the dead space area. Treatment ultimately is going to be anticoagulation, thrombolytics, heparin, transition to warfarin. Warfarin, once the clot has been resolved, warfarin may be extended for 3, 6 to 12 months or so, depending. If the patient is not able to tolerate thrombolytics or anticoagulation, if it's contraindicated in them, they may have to undergo what we call an IVC, or a filter in the inferior vena cava, sometimes also referred to as a Greenfield filter. And it's just a filter. It just catches emboli from traveling into the heart and into the lungs. And this would be sort of secondary if they're unable to tolerate anticoagulation. You could also utilize embolectomy and thrombolytic, or thrombolectomy, excuse me. Okay, so the last one here is superficial thrombophlebitis. This is often benign, usually at the site of IV infusion or at site of a varicose vein. It follows the same principle as Virchow's triad, which is stasis of flow, damage to the endothelium, which can cause some coagulation and inflammation. And what you can see over here, is that the IV site, there's some inflammation there, some redness, might be a little indurated. The vein might be clotted underneath there, and so if you feel the vein, it might feel pretty hard, and something we might call a cord. Often tender, and so the treatment for this is generally just local heat, rest the extremity, and then some aspirin, and that's usually enough to let it resolve. However, you may have to be careful because in certain circumstances, this might be actually a cellulitis and not a thrombophlebitis. They can look very similar, so you have to be aware of that. In a cellulitis, usually the erythema is much more widespread. The swelling is much more widespread, and the vein is not usually palpable, doesn't give that kind of a cord. So if you see that it's more or less just there's a hard vein with a little bit of erythema localized around that vein, that's usually thrombophlebitis. Okay. Lastly, just to kind of make sure we understand this too, is that if in a short period of time they're having this type of thrombophlebitis, but in multiple areas of the body or multiple different sites in a short period of time, then other further workup is warranted. As again, it might be a part of, let's say, like a Berger's disease. It could also be a sign of an occult malignancy. So, in certain malignant diseases, like of the pancreas, for example, it can result in something called a migratory superficial venous thrombophlebitis, and it can look similar to that. But again, most cases, you'd be able to diagnose it straight up just by knowing that it's at the IV site, for example. All right. Here's a case I want you guys to read through, okay, and then we talk live on Zoom. We'll kind of go through this piece by piece. I have some other questions for you and so on. Here, just to make sure with these questions, think it through, try to get them done before we talk live. And I want to see how you're thinking in terms of what you would order for this particular patient. What do you think are our best initial steps? And what would be the treatment? And this is just a separate case for you guys to work on. Good luck.